I'm Erin Weber, and in this video I am going to describe and demonstrate a primary survey, which is the first phase in our assessment of the traumatically injured patient. It is my hope that after watching this video you will be able to describe the components of the primary survey, list at least 2 interventions to life threats to a patient's airway, breathing, or circulation, discuss 2 ways to assess for disability, and list 2 considerations when exposing the trauma patient. To begin, before we make contact with our patient, we must ensure that the scene is safe. Once we have established scene safety, we can proceed. The aim is for us to conduct the primary survey in a systematic manner. That is, the same way every time, so that we don't get deterred by distracting injuries. This assists us to quickly identify life threats and to provide immediate stabilization when a life threat is identified. For the purposes of this video, I will state appropriate interventions, but I will not discuss them at length. The primary survey consists of A for airway, with simultaneous C-spine precautions, B for breathing, C for circulation, D for disability, and E for exposing our patient and protecting them from the environment. So let's begin. When assessing airway, I can start by talking to my patient. Hi, I'm Erin. I'm a nurse. Are you okay? If my patient can talk and respond to me, then by definition they have a patent airway. However, if my patient attempts to respond but it is impaired or they do not respond at all, then I will need to assess further. I will start by opening and inspecting the airway, being careful to protect the C-spine. I'm looking to see if the tongue is obstructing the airway. I'm looking for any loose teeth or foreign objects. I'm looking for any blood or other secretions. I'm also looking for swelling. It's important to remember that if my patient has a patent airway initially, there are certain factors which can increase their chances of losing patency. This may include things such as facial trauma with active bleeding and crepitus, thermal and inhalation injuries which increase the risk of worsening edema, and high C-spine injuries. The saying goes, C3, 4, and 5 keep the diaphragm alive, so an injury here will likely impair my patient's respiratory drive. Initial interventions might include a head tilt chin lift. However, the preferred method in trauma patients is a jaw thrust because it does protect the C-spine. We may also need to consider removing foreign objects, suctioning blood and secretions, inserting an oropharyngeal or a nasopharyngeal airway, and preparing for endotracheal intubation. Once I have ensured a patent airway, I will move on to breathing. Here I'm inspecting for spontaneous breathing. I'm looking for equal chest rise and fall, and at the rate, rhythm, and effort of my patient's breathing. I'm looking at my patient's skin color and integrity of the chest wall. I'm also going to auscultate the lungs bilaterally on the anterior chest. If my trauma patient is breathing effectively, I should still consider the administration of high-flow oxygen via a non-rebreather mask to support potentially other injured tissues. If my patient is breathing ineffectively, then I should consider supporting them with assistive measures, such as assisting respirations with a bag valve mask, performing needle decompression for a tension pneumothorax, applying a 3-sided occlusive dressing for an open pneumothorax, as well as setting up for chest tube insertion or definitive ventilation if my patient requires intubation. So long as I have ensured I have a patent airway and my patient's breathing is managed effectively, I will move on to circulation. I will palpate a central pulse, either the carotid or the femoral in adults. I will inspect and palpate the skin for color, temperature, and moisture. I will assess capillary refill and look for obvious signs of bleeding. I will auscultate a blood pressure or delegate this to a team member. If I cannot auscultate a blood pressure, it is said that we can approximate a systolic pressure from palpable pulses. It is said that if a patient has a palpable dorsalis pedis, they have a minimum systolic pressure of 90, a palpable radial, a minimum systolic of 80, a palpable femoral, a minimum systolic of 70, and a palpable carotid, a minimum systolic of 60. For ineffective circulation, I will want to establish access with 2 large bore IVs, or an IO if IV access is unavailable. I will want to consider administering warm isotonic fluids, controlling any uncontrolled external bleeding with direct pressure or possibly a tourniquet, and consider emergent or massive transfusion of blood products. If my patient does not have a pulse, I will initiate life support measures, including CPR, correcting underlying causes such as tension pneumothorax or cardiac tamponade, administering fluids and blood products, and preparing for a thoracotomy. After assessing and managing my patient's airway, breathing, and circulation, I will conduct a brief neurologic assessment. Both AVPU and GCS are used in trauma patients. AVPU stands for alert, verbal, painful, and unresponsive. So here I want to see if my patient is alert. Are their eyes open and are they talking to me? Or do they require constant verbal cues to respond? Do they require a painful stimuli to respond? And if they don't respond to the painful stimuli, then we'll consider them unresponsive. The other score is the Glasgow Coma Score, which is a quick measure to score the patient's level of consciousness. Scores range from 3 to 15. We're looking at best eye opening, best verbal response, and best motor response. For patients with a GCS of 8 or less, we want to go ahead and intubate. GCS of 8, intubate. We will also want to assess our patient's pupils for size, shape, equality, and reactivity to light. Interventions for disability may include testing a blood glucose, more closely monitoring ABC status, hyperventilation, or possibly administering mannitol, which is a diuretic that can reduce swelling in the brain. Last in the primary survey, we need to expose and protect our patient from environmental exposure. We need to remove clothing carefully so as not to harm ourselves, because we are no good to the patient or to our team if we become injured. We'll need to be careful to inspect for sharps and weapons. We'll also need to consider hazardous exposure and possibly decontamination of our patient. We will need to keep our patient warm via blankets, lamps, bear huggers, or increasing the room temperature, as well as consider saving clothing to preserve the chain of evidence. So now that I've described and demonstrated the primary survey, I have a few questions for you. Can you tell me what are 2 interventions you might consider to ensure the patient has a patent airway? Possible answers include the jaw thrust maneuver, removing foreign objects and teeth, suctioning blood or secretions, inserting an OPA or an NPA, and intubation. What 2 scales do we use to assess a patient's neurologic status? AVPU for disability and GCS for level of consciousness. I want to go ahead and thank you for watching this video, and I hope that you have a better understanding and will feel more confident in conducting a primary survey on your own trauma patients.